Hello, and thank you for joining us for this webinar, Updates in Prostate Cancer Treatment, which will focus on highlights from the recent American Society of Clinical Oncology Genitourinary Conference, otherwise known as ASCO GU. My name is Jeremy Patch, Senior Director of Patient Programs and Education here at Zero Prostate Cancer, and I'll be serving as your host. I'm excited for you to hear updates from our esteemed featured speaker, Dr. Yaw Nyame, joining us shortly. But before we get to our regularly scheduled programming, we're joined by Ali Manson, Zero's Vice President of Government Relations and Advocacy. She's here to give us a timely update on the importance of federal research funding. Thanks for joining us, Ali.
Thanks, Jeremy, and thank you for just a moment of everyone's time. I think that everyone here has a vested interest in prostate cancer research. Us too. You may not know that Zero was actually formed as part of the effort to create a special research program at the Department of Defense. Today, the Prostate Cancer Research Program, which is part of the congressionally directed medical research programs, has directly contributed to some of the most innovative treatments we have on hand today. In fact, I know that today's speaker, Dr. Nyame, has actually received PCRP funding to support his work. Yesterday, the House of Representatives voted to cut funding for the congressionally directed medical research programs by 57%. We don't know yet how the cut would be distributed, but it would be devastating for the programs, including the prostate cancer research program. Jeremy's given me a moment to talk to you because there's still a chance to stop this. The Senate has to vote before 12:01 a.m. on Saturday, and I'd like everyone here to grab their cell phones and text CDMRP to 1-888-824-4109 and click on the link you receive in response, or click on the link that I think Nicole's about to post in the chat right now. If you can send an email to your senators to ask them to oppose this cut to medical research, great. If you can make a phone call to your senators, that's even better. And if you can make a call tonight, tomorrow, and Friday morning, that's the best. This research is so important, and we need all of your help. It could be the difference between continued funding for work like Dr. Nyame's and a much more limited future for prostate cancer research. So thank you, and back to your regularly scheduled programming. It is hard to say. You're on mute, Jeremy.
Sorry. Thank you, Ali, for that update. We're, of course, hoping for the best, but we, as she said, we really could use all of your help. So please take action and help us. It feels like an incredibly relevant setup for today's webinar to hear about that and the importance of research investment. And then we're going to hear about these great findings from the latest major cancer conference that's has a lot of information come out of it related to prostate cancer and what could be the standard of care in the future. So thank you, Ali. And now I'd like to share just a few notes before we hear from Dr. Nyame. Today's webinar is being recorded and will be posted on our website, zerocancer.org, later this week. As soon as the event ends, you'll see a link to a survey. We would love for you to participate so we can get your feedback on this event and topics you'd like to have covered in future educational programs. Tomorrow, you will also receive an email with a link to the recording and the survey. Please submit your questions for today's discussion at any time using the Q&A box. We'll do our best to get as many questions as possible. I'd first like to thank our webinar series sponsors, Boston Scientific and Foundation Medicine. Their generous support makes events like this possible. If you're new to Zero, our mission is to end prostate cancer and help all who are impacted. Here's a little more about our mission statement, but I also want to talk a little bit more about our programs and our educational tools, all of which are offered free to patients and families. If you or someone you know is in need of resources at any time while facing prostate cancer, please share these tools and let them know we are here to help. So 0360 provides case management to help patients and their families navigate insurance and connect with financial assistance and emotional support programs. We also offer two peer support programs. The mentor program makes one-on-one connections, and our support groups are offered virtually and in person throughout the country. If you prefer online support, you can also connect with others affected by prostate cancer in Zero Connect, our private Facebook group. We also have a Facebook group for Black men and caregivers. We also have an online patient forum on Inspire. Perhaps if you're not on Facebook, you'd rather check that out. Join us for our next webinar on April 15th at 6 p.m. Eastern Time, Navigating Intimacy, Erectile Dysfunction, Incontinence, and Sex After Prostate Cancer. Please register at the link in the chat. Now, please join me in welcoming Dr. Yaw Nyame, Associate Professor of Urology at the University of Washington. Thank you for being here, Dr. Nyame. I'll pass it along to you so you can get started.
Thank you so much, Jeremy, for the invitation to participate today and the opportunity to share. My name is Yaw Nyame. I'm one of the urologic oncologists here at the University of Washington Fred Hutch Cancer Center. I guess if there are any Ghanaians on the webinar, I better pronounce the last name Nyame, as it is in Ghana. I will quickly plug the importance of the CDMRP and specifically the Prostate Cancer Research Program. DoD has supported me since the very beginning of my career. It was the first grant that I received that allowed me to do the work that we do. We have built a really large and diverse collaboration with patients, survivors like yourself, as a result of the funding that the Department of Defense has awarded us over the years, and that's allowed us to extend those partnerships to other organizations such as Zero's. Such an important part of the advancement that we see, not only in the new therapies and drugs, the new imaging that we develop, but also in the way that we deliver care and the research we do around care delivery. So I encourage everyone to get their phones out and text a number that was provided to pick up the phone and call your senators and make sure that this really important and pivotal funding that supports prostate cancer research and breast cancer research and colon and kidney and so on is protected. With that, I'm going to go into my highlights for today. These are from the ASCO GU meeting. Once a year, all of the different doctors that take care of genitourinary cancers get together, and we get highlights of sort of the latest and greatest research that's occurring in our field. And so I have a few studies that I've selected that I thought would be interesting to highlight. These are my disclosures. As you can see, they are funding disclosures, and on there you see that the Department of Defense is and the Prostate Cancer Research Program supports our work. So what I'm hoping to do is promote some open dialogue. That's not always easy to do in a webinar, but I did want to make sure that everyone understood that I am happy and happy to answer any and all questions and welcome them. So please use the chat, and hopefully Jeremy can be our arbitrator for keeping the discussion flowing. And I'm happy, so Jeremy knows, I'm happy to stop in the middle of any of these slides and answer a question if you think it's topical. One of the things that's hard about presenting research is it's technical. And as I mentioned, I work with survivors in the research that we do. And a lot of what we do starts with training. So we try to make sure we're all speaking the same language. But in doing that, I find out sometimes that we put a graph up and it makes sense to all the researchers or clinicians in the room, and it looks like a foreign language to you all. So when I put things up today, I'm open to take a minute to explain what the results mean, what you're supposed to see, and why it's significant. So with all of that, I'm going to start with the age-old debate in localized prostate cancer care. It's a question of which one is better, surgery or radiation. I think radiation oncologists, to me, as a urologic oncologist, they're a partner. I rely heavily on them. There's not a patient that I meet that I don't recommend get an opinion from a radiation specialist because it's a really great option for them to consider. However, historically, and maybe there's some remnants of that, um, it's felt like a big rivalry between the two factions. If you can't tell from this picture, I'm a diehard Oklahoma Sooner fan, and this is one of the greatest moments in college football sports. If there are any Texas fans on the webinar today, they're probably going to ask me to pull up some more current pictures from the success they've had against us recently. But I won't get too far into this. But we've treated radiation and surgery as these rivals in a way. But I think that they're really are complementary treatments in many ways. And what I hope to do is sort of highlight the results of this study, talk a little bit about the pros and the cons of the study, and then think about and provide some context on what I think we need moving forward. So, what are the challenges with clinical trials in the localized prostate cancer setting? And I think it's really important to ask this question first, because without this context, the type of approach that these investigators took doesn't really make sense, right? Because we know that when we want to compare how well something works in a head-to-head comparison as clinicians, we compare them head-to-head with preset specifications on what it is we want to measure as success, how we want to define it, and then what we think the difference will be drives how many people we think we have to put in each one of those arms. And then, as you guys may know, sometimes we want to have the whole process completely blinded, right? Nobody knows what they're getting so that it can't be biased in any way, right? And for a long time, we have thought of this approach where the computer picks what treatment you get so that it's random, and that we say, okay, in X amount of years, we're going to look at the results as the gold standard. In prostate cancer, the problem is we diagnose, which is a good problem, by the way, okay? We diagnose cancers early because of PSA testing, typically. And so treatments are really effective as a result. And so the few bad outcomes that we can see in localized prostate cancer can take 15, 20 years really to materialize, right? So time is one of the things that really works against us when we think about clinical trials. The second thing is that our treatments, because there's so much time while we're collecting data and in this process, and it takes a lot of time for us to see those few bad outcomes, it creates more opportunity for new things to come in and shake the market up, so to speak, right? So, you start treatment and all of a sudden somebody says, hey, we've got a new radiology test called PSMA, and now we can see little bits of cancer that you couldn't see before. Well, that evolving paradigm, whether it's a treatment paradigm, new drugs, or new diagnostic tools, can really disrupt those results that you produce. They can either make them irrelevant or they can influence them in ways that are unpredictable during that long time. And then I think for us here, especially in the US, the idea that a computer is going to pick your treatment doesn't sit well with anybody. And so it's hard for us to say, hey, we're going to have two groups of treatments. You guys are all presenting with the same kind of cancer, and we're going to let the computer pick what's done for you. So this is the first study I wanted to highlight from this meeting just because it generated a lot of conversation. It's led by one of our very famous radiation oncologist, Daniel Spratt, as a senior author, and a multidisciplinary team of urologists, oncologists, and radiation oncologists that did the study together with some statisticians. And what they did was they compared a clinical trial in high risk prostate cancer patients where they received prostatectomy or surgery versus radiation therapy. And what they did that's a little bit different is that they tried to use pretty sophisticated statistical technique to try and make the two groups seem as similar as possible so that we could understand what the benefit was of those two treatments and compare them to each other. Okay. Now, one of the things that I want to do when I put a picture like this up is just say, okay, these are the two trials, right? The PUNCH trial and the NRG 0521. High-risk prostate cancer, okay? So you can see under each bracket, we have the term high-risk prostate cancer. And then they have a definition of the entry criteria for what made you high risk, right? But what you'll see is even looking at the far left side of these two groups, the definition of high risk is a little bit different between the two groups, okay? So not only are they getting different treatments, but they're not exactly the same defined population as high risk. And then you'll see that for the radiation group, and the surgery groups, there are two arms. The surgery group is they were either randomized to surgery or getting before surgery chemotherapy and hormone blocking therapy, ADT. Whereas in the radiation group, everybody got radiation with long-term hormones, and then a second group within that study got the addition of chemotherapy. Okay, so right off the bat, you can see there's differences in who was in the study and differences in what the treatments types were. All right, so one of the things you can do when you want to compare two groups is you can just look at them, right? How many 2% of the people on this side had their cancer come back or developed stage 4 cancer, 5% in this group. So 5 is bigger than 2, so the 5% group was worse than the 2%. So that would be kind of the simple abacus level math. Or you can get real fancy and you can say, well, what do we know about the people that were in this group that had 5%? How old were they? Did they have heart problem? Did they all get treatment? And so you can imagine you can get all this fine level of detail about those individuals in both groups. And then with the computer, you can say, okay, if we tried to make these attributes of these two populations the same, how do they compare then, right? And that's what we do when we talk about our statistical models and regressions. That's usually what we're doing, right? We're trying to account for certain variables to see how that influences the outcome that we see, okay? I think this study is somewhere over here. There are these emulation trials where you can extract what you think the benefit of a certain intervention was. And that's usually very detailed. So you extract that benefit off of all these different variables, and then you can apply that to another data set that's really big. So you can say, okay, what's the benefit of surgery and radiation in this setting? And then go to like VA population where you have a lot of patient data, and you can try and run that same trial in that VA setting. But this study is a little bit different than what I would call that supercomputer version of high tech that I have here in this slide. So when they balance the two groups using this fancy statistical approach called inverse proportional weightings, propensity weighting, excuse me, what they found was that the surgery group was more likely to develop stage 4 cancer than the radiation group. And what we look at when we have these curves, because we call these event curves, so we're looking at over time how many of these events happen. So each one of these little ticks over time is a case of metastatic cancer, okay? And you see at the bottom we got an 8-year horizon here, and then on the y-axis is this incidence. So how many people over time are developing stage 4 cancer? And so in total, it was 23% for this very high risk group in the surgery, and it was 16% for radiation. And the difference is significant. And sometimes the way that we as clinicians and researchers know that the difference is significant is we look at the two lines, and if they separate from one another or if they're not touching, then we know that difference is meaningful. Those two groups are having different experiences. Okay. So that was kind of the main takeaway was maybe this radiation approach with long-term hormones is better than a surgery first approach, even when surgery is followed by additional treatments. Um, so 7% better, okay? But the radiation group was more likely to die from a non-cancer cause. Now, a lot of reasons to explain that, and in general, radiation is administered to older individuals. It's a first-line treatment also for individuals who may not be good surgery candidates. And to be a good candidate for surgery, typically you have to be healthier. So that might be one of the reasons that was seen. There's some hypothesis about maybe the combination of treatments, but what I want to be really clear here is we don't know exactly why this observation was made. We just know that it was there. Okay. The other thing that is pertinent to point out is I said this earlier that the surgery group, they got surgery and then they had the option of just being monitored and getting more treatment if they needed it, or getting a little bit extra treatment if the numbers from surgery were concerning as far as like how aggressive their cancer was. And then the other group got chemotherapy and hormone block in what we call neoadjuvant fashion, so before surgery um, was administered. And the group that got that combination treatment before surgery was administered, they actually had similar outcomes to the radiation group in this study. And I mentioned this earlier. I said, how do you know if a study is successful, or if the difference between the two groups is meaningful? Sorry. And what you can see is these lines start to separate here, and then all of a sudden, right in the middle, right around year 4, between year 3 and 4, you can see these lines are kind of touching, and it happens a couple of places. You see here in year 7, they're really close here in year 6. And so anytime those two lines are that close, or if they're touching, then the differences that we see overall are not meaningful. So there was no difference between these two treatments. So what do I take home from this study over, the main take home is this is an important question. Like we want to answer this question. We're using fancy statistics to try and answer it. There are more opportunities to use fancy statistics to answer this question, but truthfully, we need a trial to do this for us if we think that it's important to understand the difference and success between these two approaches, which I think it is important that we know that. The future, we may get some results in the future and soon from this Scandinavian trial, SPCG5. It's already happening. The results haven't even published, and we're scrutinizing the results because, as I mentioned earlier, practice is evolving. So when this study was designed, they allowed for a certain type of hormone block. Now, fast forward all these years later, we have new standards and new treatments, and so folks are already saying, well, the hormone type of treatment, that hormone blocking treatment that's in this study, well, it's not very good. Well, it's what was it was in line with standard of care when the study was designed and executed. So SPCG5 will give us results. I'm also an eternal optimist. Even OU and Texas, University of Oklahoma and Texas, two bitter rivals, put their differences aside to seek greener pastures in the SEC, and they had to do that collaboratively. So I believe that our radiation doctors and urologists like myself, that we can come together to design this type of study. And I know there have been some efforts over the last few years, including some that have been discussed by some of the people that I work with about doing this. So stay tuned, but hopefully we can have some more clarity about which approach is safest and most effective when it comes to high risk cancer. I would say right now, either surgery or radiation are still really good options for patients. So I'm going to fast forward now from this localized setting to the other end of the spectrum where we've had a lot of advance in treatment, and that is in the hormone-resistant prostate cancer space. And as you may know, most of the time when we develop a new drug, we test it in this setting, and then it moves backwards in the timeline of cancer to earlier and earlier. And all of our biggest advances like abiraterone, docetaxel, enzalutamide, they've all first have been used and been proven to be effective in the hormone resistant setting before going then to the hormone sensitive and even sometimes the locally advanced setting. I show this chart because of how many options we have now. So when I started in urology, which was not that long ago, uh, when people progressed from local therapy or if they presented with stage 4 cancer, you really had hormone blocking treatments. And if you looked at the slides at that time, you would essentially see a hormone block of one or two variations on this slide. And then if people progressed, there was the option for chemotherapy to be considered. And then, as I have mentioned, over time, we've added more and more treatments, immunotherapies, more chemotherapy. So the immunotherapies on this slide, pembrolizumab, Sipuleucel T. We've added more chemotherapies. I mentioned docetaxel earlier. We have these novel anti-androgens, as we call them. So abiraterone or enzalutamide that in a clever way block testosterone, which we know is an important fuel for prostate cancer. We have these radiation-based treatments. So we've seen like lutetium come into the space and radium-223. And so it's just we have a lot of options, and a lot of it's being driven by what we know about the biology of cancers. One of the things that is a hallmark of cancer is DNA damage repair. Cancer cells, they are replicating so fast that they are making bad copies of DNA, okay? And basically, as a cancer cell is making copies of itself so quickly, it's turned off its spell check to make sure that the code that it's writing is accurate. Now, a normal cell will have mechanisms to fix these DNA copies. And in fact, that abnormal DNA is part of what some cancer cells are relying on to kind of develop that explosive growth that they see. So there are medicines that can there is a number of processes that allow this process to either be in check or not in check. And one of the things that has become really clear is that either people are born with DNA damage, repair gene alterations that don't allow them to fix these DNA and have more normal cell activity, or recognize this damaged DNA and destroy the cells that have abnormal DNA. But it also seems like that can be something that is acquired over time in the cell. And one of the ways that the body recognizes and fixes these abnormalities um, is with this enzyme called PARP. And PARP allows the cell to go in and fix these errors, and that can be beneficial for an abnormal cell to stick around, right? So cancer cell, if there's PARP there, might be able to fix some of these DNA damages and not get sent down the pathway of destruction. So this PARP inhibitor blocks PARP and prevents the cell from fixing these errors, and the body recognizes those cells as damaged with damaged DNA and then sends them down the trash chute pathway, okay? Now, the question has always been, are people who have DNA damage alterations in their genes, either acquired or something they were born with, more susceptible to these PARP medications and sending these abnormal cells down this pathway? And a couple of different studies have looked at these PARP inhibitors in hormone-resistant prostate cancer. And this TALAPRO-2 study is really a landmark study in that it gives us a result that's somewhat interesting. The study had two cohorts. You can see here that there's cohort 1 and cohort 2. And cohort 2 was published first and actually is in guidelines. And what they showed in cohort 2 was that if you had a DNA damage repair gene alteration, especially one that's in this homologous recombination repair, I'm a urologist, y'all. So if you have a lot of questions for me on this like nitty-gritty detail of this biology, I'm not going to have good answers for you. But these are genes that you're familiar with, right? You guys have all heard of BRCA1 and BRCA2, CHEK2, and you see the list here in the middle. So ATM, ATR. Um, but if those were present, they showed that the addition of this PARP inhibitor, this medicine that blocked the body's ability to try and fix damaged DNA, improves survival. And so in this year's meeting, they presented data from an unselected cohort. So not looking to see if you had that alteration, but anybody could be enrolled in the study. And they wanted to understand if this PARP inhibitor talazoparib combined with enzalutamide was better than enzalutamide alone. All right. And what they wanted to measure was whether or not the cancer progressed on treatment. And so the main result from this year, again, we look at these curves, and what we want to look at is whether or not they separate from each other, and if they stay separated, right? Because if they start to touch at any point, or if they come back together, maybe there's no benefit. And what they saw here was that regardless of the mutation status, if you got this combination of this PARP inhibitor, tele, um, talazoparib and enzalutamide, that you had longer survival even at this really with this really aggressive form of advanced prostate cancer compared to enzalutamide alone. And this creates a new standard of care. It's a almost 9-month improvement, which is just a median improvement. I always highlight that. That means some patients can get this kind of combination and have longer survival than what is listed here. Obviously, some can have shorter, but it's really wonderful that we have this option. And it seems to be independent of some of the biologic links that we expected there to be. Lastly, I'm just going to highlight lifestyle because this is something that I get asked about in my practice all the time. You know, when I see a new patient diagnosed with prostate cancer, they always say, Doc, is there anything I can do? Right? Can I eat better? Can I work out more? The answer is always yes. And I have a kind of a cheesy line. If it's good for your heart, it's good for your prostate cancer. And I believe that lifestyle modifications can be a positive part of your cancer care. I think it helps mental health to feel good and be proactive. And there's some evidence that it may help with your cancer biology too. But I will say on that second part of it, that's where it gets really tricky. There've been a lot of lifestyle modification studies that show that change, assess whether a change in diet or more exercise can impact cancer outcomes. In general, most of these studies show that the lifestyle intervention works, meaning if the goal was for you to do more exercise and lose weight, that people are able to successfully get on a workout program and successfully lose weight. If it is to change cholesterol levels or to, lower sugar levels, I mean, most of the interventions show that whatever diet or diet or workout plan that's put in place works. Where it's been a little bit less clear is what the cancer benefit has been. So the rates of, let's say, active surveillance patients that have subsequent reclassifications of more aggressive cancer found on a future biopsy, that doesn't seem to change, at least based off of the studies that have been published to date. So this catfish trial wanted to compare the regular diet to what I'm calling the Italian-like diet. So high in omega-3, low in omega-6, plus a fish oil supplement. And the reason that there's interest in this is there's been a lot of studies that show that fat itself can be a part of the communication pathway, and fat cells can sometimes communicate in a way with prostate cancer cells that lead them to replicate more frequently and maybe even migrate. It's a really lovely French study that was published in Nature Communications many, many years ago now that demonstrated that. So what the study showed was that for the people who were put on the intervention, this low bad fat diet, high good fat diet with the fish oil supplement worked. So omega-3 is a good. DHA and EPA are forms of omega-3 acids. And you can see that in the group that was on study that got the intervention at 12 months, their bars went up. Okay. And then they were able to decrease their bad fatty acids, the omega 6s, at 12 months by doing their diet control. I think perhaps most importantly, if you look here, for those that might have a scientific background, Ki67 has always been a marker of what we call cell proliferation, or, a better way to think of it is cell activity. How likely is a cell to divide and be active? And definitely has been a marker that's been associated with increased risk of cancers progressing, meaning moving to a higher grade or higher stage, and other clinically meaningful endpoints. And so they did show that cell activity in those who got the treatment, this tannish box, had lower Ki67 activity compared to the controls that kept their regular diet. So main take home though was that there was no difference in the outcomes at biopsy. There was no difference in their genomic decipher score. There's no difference in PSA or testosterone levels. And I think this again points to the challenges that most lifestyle studies have had when it comes to showing that big cancer benefit. So the key takeaways I have from this really wonderful and interesting study is that these types of studies are difficult to do. We don't understand what the impact of time is with regards to diet interventions and exposure. It's hard to find that meaningful endpoint of, are we decreasing the number of people that need to go on to treatment when they're on active surveillance? This study was done in an active surveillance population, so people who are having low risk cancers monitored. However, I think it's really important to point out that the diet low in saturated fat and high in omega-3 acids did seem to help in one marker of cancer activity. And more importantly, I would venture that those men on active surveillance that had that diet felt better, had better heart health, lower blood pressure, maybe better sugar, and overall felt better. So I'm a big proponent of lifestyle interventions. And I think even if the benefit isn't a slam dunk for reducing cancer risk, the overall benefits tend to outweigh any risks that might exist. So with that, I want to say thank you to Jeremy and the Zero team, as always, for giving me the opportunity to present in the webinar. This is a photo of our backpack team. These are the gentlemen I mentioned that I do research with here at University of Washington, and our research team and some of our collaborators on the rooftop of the Fred Hutchinson Cancer Center. And if you look really closely, you'll see a lot of Zero champions, Zero survivors, many of people that are part of your community that engage with our team as well, like Marty Chikoyan there in the back. And so I do want to shout out these gentlemen who really make the research that we do possible and impactful. So with that, Jeremy, I'm happy to answer any and all questions that you may have from
Yeah.
the.
And thank you so much, Dr. Nyame. Appreciate that great presentation and an overview of some of those recent conference highlights. And we do have a lot of questions, as you can imagine. I think I'm going to start with one that was most related to the one you just finished, the lifestyle one. And the question was, were supplements included in that lifestyle modification research?
Yeah, the supplement that was included was a fish oil tablet, and I didn't include the details on the exact dose um, for that supplement. But yes, they were given strict instructions on which foods that were good, high in omega-3 and low and high in omega-6, and they were asked to catalog what they were eating and avoid the bad and increase the good, and then they got a fish oil supplement on top of that.
Thank you. Um, So one question, the one the one of the studies you covered before that was the Talapro 2. Were the questions were the patients randomized by computer?
Yeah, standard randomization that is done for a clinical trial like that. So
Yeah.
followed blinding and randomization protocols.
Okay. Thank you. We had a few questions about ADT. So let me see if these are related. Now I'll separate these. So, the first is what men have best results from intermittent ADT?
Yeah, I mean, there are a lot of studies that show that intermittent ADT is as effective as continuous ADT. I think that really its use depends on how symptomatic a patient is. And I certainly advocate for patients who have a lot of symptoms on ADT to be on intermittent ADT regimens when it's feasible.
Okay. And the next question is very much related because why do people go on intermittent ADT? Because the side effects are they want to avoid those side effects.
That
So
is
the
the
next
main,
question,
yeah, and that was the reason it was studied initially. It was because of how symptomatic an average patient that has to be on hormone block is, as
right.
some of you may know. So.
So and this question is since the side effects can be so bad, can you comment on the overuse of ADT?
I mean, that is an interesting way to think about it, overuse. And
Yeah.
I think one of the things, so a lot of things were discussed at the meeting that I didn't get to. A lot of talk about PSMA, as you can imagine, a lot of exciting results that are forthcoming in the realm of PSMA-based treatment and
Yeah.
PSMA-based diagnoses. And, one of the things that continues to happen as we talk about prostate cancer therapy is that we keep adding more and more. So when I started, there was singlet, I'll call it single therapy. It was ADT. Then there was doublet therapy, charted trial. We had studies that showed if we added one more thing, we could get a lot of benefit. Now we're at triplet therapy, right? And now we add radiation to that. That was that slide I showed. Well, one of the questions has come into our field is like, well, when do we start to de-escalate all of that? When can we start removing certain therapies? Would it be harmful to do that? And I think the algorithm for that is really challenging. The discovery that taking away testosterone affected prostate cancer was a Nobel-winning discovery from the 50s. And that, hormone blockage has been the fundamental foundation for which we treat advanced prostate cancers. And so it's hard for me to think of a scenario in which that wouldn't be part of treatment because of how effective it is. Um, However, and we know that from all of the science that's been done to date showing the strong relationship between androgens like testosterone and cancer activity and but as we learn more about the biology, what may happen, and I think that I presented Talapro 2, there might be some medical oncologists who'd still disagree somewhat with this results and would say, well, if someone has a certain mutation or certain biology, this treatment makes sense, but if they don't, why would we give them this? That might be a world we live in for ADT, where if someone doesn't have a hormone-driven cancer, maybe there's going to be a different drug that is more effective that we can utilize. Um, so I long answer, largely philosophical, to say that, the for now the bedrock treatment for advanced cancer is going to be hormone blocking, but there could be a future in which we choose different therapies that don't involve that, purely based off of cancer's biology in response to maybe other treatments.
Thank you. Another question, are immunotherapy and PARP inhibitors only for castrate-resistant patients?
No, this is going a little bit out of my comfort zone as a urologic oncologist. I'm not prescribed, so full disclosure, I'm not prescribing these drugs very often, if ever. No, well, I'm never prescribing them, but I'm not dealing with them very often. Um, as I mentioned before, the PARP inhibitors have come into the mainstay really in this setting of advanced cancer because there's a higher likelihood of these DNA damage repair gene alterations. So up to 25% of these advanced cancers are going to have compromised DNA repair where they are really susceptible to this type of treatment. In patients who have DNA damage repair mutations, there can be opportunity to move, and certain alterations, there are opportunity to move this type of medicine earlier in the process of treatment. And there are even some ongoing clinical trials that are trying to look at the efficacy of these types of medications in earlier stages in improving survival. Um, and with regards to immunotherapy, prostate cancer has proven in a lot of ways to be non-responsive to our immunotherapies, although again, there are a subset of cancers that have that are high in genetic mutations and alterations that may be sensitive to some of these immunotherapies. So it's quite customized, and there are small subsets that respond, but these are not classes of medications until really talipro, which is a specific population of patients. But like for the larger prostate cancer community, these are not two therapies that we give to all patients and they all do well with it.
Yeah. I'm going to jump back to some of the early, kind of related to the first study you presented on. And so how would side effects impact the surgery versus radiation question, sexual function, and urinary tract issues?
So can you reframe that one more time?
Yeah, how would side effects, and I don't know if this, what the all the
Con
endpoints of the study were comparing surgery versus radiation,
ah,
but did it consider side effects such as surgery versus in looking at surgery versus radiation, such as sexual function, urinary function?
what a fantastic question. No, it didn't, right? And that's another advantage of what we call a prospective study. If we were going to do a comparison of surgery and radiation ahead of time, do our best to make the two groups the same and then look, 10, 15 years down the road to see how the two compared, it would be impossible to design that and not have one of the outcomes that we measured be quality of life, or what we call patient-reported outcomes. But when we look back in time, we're often can't do that kind of study. Either the data was not collected, or if it was collected, the two groups are so different that it's not appropriate to compare those two groupings. So there is no quality of life data. I will say that the treatments that I showed that were effective were essentially radiation with long-term hormones plus, or minus a chemotherapeutic, seem to be fairly similar in outcomes to surgery plus chemo and hormone block. And that is, both of those are very toxic combinations that have big impact on quality of life. So that can't be diminished. But within that surgery, this study, you have a surgery group that may have gotten radiation as well, which also has, as a combination, has its own unique toxicity profile. So something to definitely keep in mind for the future.
Um, Thank you for that. Always important to consider those quality of life issues. Um, I'm just reading this one question. Sorry, sometimes they're long and I want to make sure I look at them to get all the information. Um, what have studies indicated that men that get surgery for removal of the prostate as opposed to radiation, what have they found as a percentage of men that may need follow-up treatment? Um,
Yeah. So it depends. And when I see a patient, I always bring this up. You know, going into treatment, about 20% of prostate cancer patients recur or have their cancers come back after their primary treatment. And we quote really high rates of success with treatment. But one of the things that I always try to clarify is that may include a second or third line treatment after you get your first treatment. So 1 in 5 surgery patients have their PSA go up, which is a very, very reliable marker of cancer returning, and require more treatment. And in the setting of surgery, that more treatment, uh, the majority of the time is radiation treatment. Um, but depending on how aggressive your cancer is, that risk can go all the way up to 50% for a true high risk patient that might have like a grade group 4 or 5, your Gleason 8 through 10 cancer, or cancer that's outside of the shell of the prostate. If any of my patients are on, I always compare the prostate as an apple after surgery when we're talking about location. And cancers can be either inside the core, the main shell of the apple, so in the fruit, or they can be on the skin of the apple. That would be that extra prostatic extension. And something like extra prostatic extension is a high risk feature that increases the risk of recurrence in an average patient about twofold.
um, After a radical prostatectomy, and then when the PSA increases to the level of, potential biorecurrence, at what PSA level would you feel comfortable ordering a PSMA PET scan, to find out more?
Yeah. So this was answered by the AUA guideline panel and I was a member of that panel. This was one of those good questions that we wanted to make sure we gave some commentary on. It's important to note that the PSMA sensitivity, so its ability to find small amounts of cancer goes up the higher your PSA is, right? So when your PSA is above 1, it's kind of when the test uh, is functioning at its peak for being able to find things. But we also know that from a clinical standpoint, when you start to get above 1, we're losing the opportunity to cure with that second line treatment. The other next cut point is it's a little bit less, it performs a little bit less at 0.5, and then below 0.2, really, you start to have rarer amounts of positive testing. So I think many of us follow what the guideline panel said, which is 0.2 is when we define recurrence. Why not order the tests at that point? But it's important that you counsel your patients that it's about a 50-50 chance that PET scan will show anything. Um, and so, I think that's probably the best guidance we have based off of what's available in the literature as far as utility of PSMA PET.
Okay. Thank you for that. I just know that's a common question. People are kind of looking,
Sure.
monitoring that rise and with the advances in PSMA PET. So,
Yeah. And if it's
um,
negative, you can still get treated, number one. And number two, you may, in discussion with your treatment team, say, you know what, we're going to wait a little bit now. If it's really important to try and understand where things are, we may wait 3 more months, check another PSA. And if it's increased a little bit more, repeat that PSMA PET scan to see if now we can find the source of that activity. So it depends on what your first treatment is and kind of what the goals are, but there are ways to use a PET scan multiple times to sometimes help locate areas of suspicion and direct treatment.
Okay. Last question, because we are almost at time,
Yes,
and
sir.
this one came in pretty early. Can you comment on focal therapies for localized prostate cancer?
Yeah. Again, a topic that was represented at the meeting. Focal therapies are still, I think, in that developmental phase, in the sense that we are just scratching the surface on their full utility in our field. But I think they're going to be a very important part of prostate cancer care because they offer, in theory, the opportunity for benefit while reducing harm, right? And I think all of us believe in that. But so far, the data shows high rates of recurrence after focal therapies. Um, that's going down, I think, as the technology gets better. But I base this off of a systematic review that was published in European Urology that shows that recurrence rate can be 50% or higher if you're using biopsy. Um, I will say that from a focal therapy standpoint, prostate cancer will always have challenges. Cancers are typically small and not always easy to detect with a picture, like an MRI. And prostate cancer tends to be multifocal, meaning it's in more than one spot. So it does, when it presents in those classic ways as small tumors that are in multiple spots, it can just create a challenge to treatment. What I would advise for any one on this call that's considering focal therapy or has been diagnosed is to ask about it, to get some information, to understand if it's suitable for you, meaning will you benefit from undergoing a focal therapy? And just generally, my rule of thumb, can't be too aggressive. So grade groups 2 and some 3s, but really that Gleason 7 range. It's important that we can see it on MRI. So, it has to be MRI visible, and it's important that it's not multifocal, right? Right. And so if it meets those criteria, then I think at the very least it's worth a good discussion with an expert that does focal therapy to see if you could benefit from one of those treatments.
Okay. Thank you. That's helpful guidance. Well, and that is all of our time. So thank you so much, Dr. Nyame, for an informative discussion. As we close today's webinar, I want to remind you to please, you all joining us, to please fill out our short survey and to look out for an email with the recording of today's webinar in case you'd like to share it or listen again. So we did record today's webinar. We always share those to our website, so look out for that email. Thank you for joining us today. Dr. Nyame, again, thank you. Great information. Really appreciate you presenting it to us. And thanks to everyone. I hope you have a wonderful day.